Hello, my dear friends and colleagues. Pavel Krastev, DDS, on behalf of Global Summits and myself, I welcome all of you today. It's a very, very special day today, and to all mommies out there, a very, very happy Mother's Day from all of us at Global Summits and myself. You guys make the world go around, so all the moms out there, we love you all, and we kiss you all, and keep up the great work. So we started the day today, great day. Dr. Shah and Dr. Jeremy did a beautiful presentation. And today I'm going to be introducing you to a new friend of mine, Dr. Hakan Bilhan from Germany. And we're going to be talking about a very interesting topic that I'm very passionate about, which is socket preservation. And socket preservation, I believe, is a huge asset to any practitioner, and it does a tremendous service for the patient because it prevents bone loss, especially if you're planning to replace the site with an implant. So I think it's a great tool to have in your pocket, and especially, for example, if how often do we lose a second molar, and you end up with this big hole behind the first molar. And if the first molar's distal bone is compromised and then you don't graft it, very often you end up, really compromising the first molar. So I'm a big fan of grafting sockets. I think all general practitioners should be routinely doing this daily in their practices. And because, like I said, it's a great service to your patients. Now, before we get into the presentation and before I officially introduce my new friend to you guys, the doctor-to-doctor movement is rapidly growing, and with global summits, we initially we started with dentistry, and now dentistry is sort of exploding, and we're taking nominations for 2023. So now we're branching into medicine, chiropractic medicine, pharmacy, optometry, and philosophy. So we encourage all colleagues in these professions who are doctors to nominate themselves, nominate friends that they know and respect, who can bring something to the table and share with our audience. So feel free to help us grow, essentially. Okay, so we'd love to have you involved in that. The other very important housekeeping note is at the end of each session, you can earn 1 CE unit, continuing education credit. So make sure the link will go up so that you guys can use it. So let's bring Dr. Hakan Bilhan to stage. Dr. Bilhan, welcome. We're very happy that you're joining us today. And I want to thank a big shout out to a dear friend of mine that is also in the top 100, Dr. Andreas Van Orten out of Germany. He introduced me to Dr. Bilhan, and he said, Pavel, Dr. Bilhan did such a fantastic lecture on this topic that let's do a show, and this is how I met my new friend, Dr. Hakan. And thank you, and again, Andreas, big shout out to you. So Dr. Bilhan, I'm going to read your resume. And before I read it, I want to mention Dr. Bilhan sent me 2 resumes. One that was so long that I started scrolling down. I mean, I kept scrolling and I couldn't reach the end. And he also sent me a shortened version. So he's a very accomplished, very well respected, and very well-known colleague. And it's really an honor to have him with us today. So I will be reading today the short bio, but don't be fooled. And I encourage all of you to maybe log on to his website, or I'm sure he can maybe post it up in the comments so you can see his full bio. So Dr. Hakan, I recommend maybe you can throw a link to your full bio in the comments section. So let me read your bio, and then we'll jump in and you can tell us a little bit about yourself, and we'll delve into the presentation. Let me get my eyewear on. So Dr. Bilhan has received his DDS DMD degree in 1993 from the Hacettepe University in Ankara, Turkey, followed by a postgraduate certificate study in oral surgery and implantology at the Karl Franzens University of Graz, Austria. He earned his Dr. Med Dent in 1996 after a 2-year stay in the Department of Oral and Maxillofacial Surgery of Zurich University in Switzerland. His PhD degree in prosthodontics in 2004 at the Istanbul University. Dr. Bilhan, who became associate professor in 2012 at the Istanbul University, was the founder and chair of the Department of Prosthodontics in Okan University School of Dentistry between 2014 and 2017. He lives in Germany since then. He published several book chapters and numerous scientific papers in peer-reviewed international journals. He's a member of several scientific academic societies. He gave a myriad of presentations at the national or international conferences, and his fields of interest are mainly removable implant prosthodontics, edentulysm, periodontology, implantology, and gerodontology. He is presently senior consultant and associate professor in the Department of Periodontology at the Witten-Herdecke University, Germany. So once again, Dr. Bilhan, welcome to the show, and great to have you. So tell us a bit about yourself, and following that, we will be more than happy to see your presentation on socket preservation.
Dear Pavel, thank you very much for the kind introduction and nice words. I hope I will not disappoint you. You have told everything, but maybe I can add only one thing. I was privileged to be able to visit university departments of oral surgery, prosthodontics, and periodontology in my career, and that was accomplishing my mission in implant dentistry, which was very interesting for me. It was the main field of my interest, and I think I was lucky to be able to be present at the university all the time. I would like to thank Andreas von Orten for the nomination, and Professor Shah and the whole organization for the invitation. I'm very excited and hope everybody likes my lecture. I want to send my greetings to all the mothers on this Mother's Day. And the last thing I would like to say is, before I start, I would like to assure the audience that I do not have any conflict of interest. It's only my experience and honest presentation.
Thank you for that. Thank you very much. Now, tell us a little bit before we delve into the presentation. What motivated you to go into this field and develop such a passion for implantology?
I was always interested, even as a student, interested in oral surgery. I was visiting the departments even when I was a student, and in these years, in the early 90s, the implantology was coming up, and I saw it was a coming field, a very modern field which had future, and by coincidence, I was drawn in this field.
Wonderful, wonderful. Well, in that case, Dr. Bilhan, I turn the podium over to you. We look forward to your presentation. Enjoy.
Thank you very much. I hope I have succeeded. Pavel, is it okay? Can you see my screen?
Yes, I can. It looks fantastic. Please go ahead.
Thank you very much. So then I will start. I would like to start with the changes in the alveolar bone following tooth extraction, then talk about some techniques and strategies to prevent the atrophy, have an overview of biomaterials and treatment modalities, and also, of course, tell about my personal roadmap and my recommendations. What happens indeed after the loss of a tooth in the alveolar bone or the ridge? As we all know, there will be a loss of volume, which is inevitable. After every tooth extraction in the ridge, there will be a volume loss of the bone, which will cause difficulties later on if we plan to implant. As you can see here in a three-dimensional way, after loss of teeth, the alveolar ridge will lose bone volume, as in a case like this. If the molar is extracted, after a few weeks, you will see this image clinically where an implant placement is not possible without any measures, any additional measures. This is a 3D view of the alveolar ridge. You can easily see that no implant would be possible to place here. You need additional measures. So is ridge atrophy unstoppable? Yes, we can say yes. If we do not prevent it, there will be an atrophy of the ridge following the loss of the teeth. I like to show this model to the students because it is very demonstrative. You can see the lower jaw with teeth, and after the loss of the teeth, you can see the following atrophy of the ridge. There are a lot of studies published about this subject. We know now that the ridge width is lost about 50% in the first year, and 2/3 of this 50% in the first year occur in the first 3 months. So we have to hurry up if we want to place an implant, or we have to have preserving measures. Today we are able to see also the sagittal view of the socket, what's happening. In a study from Switzerland, you can see here the sagittal view of the socket after tooth extraction. In the first image, it is a thin phenotype of bone wall, which after 8 weeks totally disappears. And in a thick phenotype of bone, you can see in the lower part that there is still a buccal wall after 8 weeks. If we would wait longer, let's say for 6 months, even this buccal wall would disappear. So following natural healing of extraction, the vertical dimensional reduction amounts about 11 to 22% after 6 months, whereas the horizontal dimensional reduction is greater. It's amounting up to 63% after 6 to 7 months. So we can say that later in the next years, 0.5 to 1% reduction of the bone contour per year will be expected. In summary, following single tooth extraction, up to 50% of the ridge width will be resorbed or atrophied. The bone resorption will predominantly occur at the buccal aspect and make an implantation more difficult. This is histologically what's happening there. The healthy bone is destroyed by osteoclasts. And at the end, we have such a alveolar ridge, which is making an implantation very difficult. It's not because of only implantation, it's also bridge pontic would also have aesthetic problems due to this missing volume. And we have to go augmentative with augmentative procedures, and also with invasive methods maybe to gain bone or volume again. Our goal would be to keep the bone volume like this, as you can see here, clinically and radiographically, so that we have at the end, at the time of implantation, enough sufficient bone volume. We know that preserving is more predictable and more economic than augmenting later. Generally, if we augment, this is an image from Professor Fickel's courtesy. He had preserved on the left side, and on the right side he had an normal healing. And you can see there's a severe difference between both sides. We know that implants placed in preserved sockets are shown to be more successful. They have a higher survival rate. If we do not preserve the bone, we will, at the implantation timing, we will have deficient bone, as seen here. It could be either a fenestration, which is better than a dehiscence defect like seen here, and even worse, bone loss after implant placement in the coming months. That would be disastrous. So if the opportunity of socket preservation is missed, we have the only possibility to augment. These are most of the time advanced methods, like in a Curie technique, which you can see here. You can use autogenous blocks, maybe also allogenic materials, but it is not an easy task. You can also use the traditional membrane and grafting materials, or it was once very fancy to use pins. Or I have for the first time seen this method with Professor Friedman, where he used a collagen block. It is a Ribose cross-linked collagen block, and covered with Ribose cross-linked collagen membrane, as you can see here, for ridge augmentation purposes. And it is seems to be very successful. I will talk about this collagen block later on again. So in order to prevent these advanced surgical procedures, why not preserving the socket after extraction? Our goal would be keeping the bone volume, which is then afterwards filled with vital bone structure suitable for good implantation. There are a lot of studies in the last decade concerning socket preservation, and one of them, which was very impressive for me, was from a Swiss group from Zurich University, Ronnie Jung and colleagues, where they have stated, ideally, the therapeutic plan starts before tooth extraction and offers us three options. One is the spontaneous healing of the extraction socket. The second is immediate implant placement. And the third is the techniques for preserving the alveolar ridge at the site of tooth removal. They have offered us a flowchart, decision tree, where some questions should be answered in order to choose the direction we have to go. Implant placement possible or indicated within the next 2 months? Yes. Then a second question is coming. Soft tissue improvement indicated? No or yes. Or if the question is answered with no or later, the second question would be size of bone defects at the extraction socket. So we have a decision tree to help us deciding which way to go at the time of tooth extraction. So you see which way you have chosen. You have also the time to wait. If you have chosen spontaneous healing with blood clot, waiting time before implantation of up to 8 weeks would be sufficient. If you have had a big defect after extraction, you would have to do a guided bone regeneration with grafting materials and membranes and such stuff, and you would have to wait longer times. Another very interesting article was the consensus report from clinical recommendations of the group 3 of the 15th European Workshop in Periodontology, where also options were shown here for implant placement after the tooth extraction. It's a long article, but we have not sufficient time. I will concentrate on these two issues here. I will talk about immediate implant placement and alveolar ridge preservation methods. One possibility would be the socket shield technique, or which is also called the partial extraction method, where you can see here the principle is very simple. The vestibular, the buccal part of the root is kept inside, so it is kept with the buccal wall to protect it, and then an implant is placed immediately on the palatal side of the socket, so to be able to preserve the buccal bone. It would look a bit like this clinically. You see here the shield, which was divided from the root and kept in place. We need a gap of 1 to 2 millimeters between the implant and the socket shield. And the implant, you see, is always on leaned on the palatal side to avoid false buccal positioning. So you can see there is a gap between the shield. The shield is protecting the buccal wall from atrophy. Here, another case, as you can see here, carefully divided root, and the other parts are removed, and a shield of 1.5 to 2 millimeters is left in place, a gap kept between the implant and the shield. There are also special instruments for this purpose. It is important to know that the coronal border should be 3 to 3.5 millimeters subgingivally. There are some rules we have to keep in mind if we want to use this technique. The first one is the tooth should not have any periodontal problems. The second thing is there should be a residual lamellar bone buccally. I mean, if there is on a sagittal view no buccal bone lamel, this technique would bring nothing. So there is no bone to keep. This bone should not be damaged during the extraction. I mean, the extraction should be very carefully accomplished. The shield should not be luxated during extraction. It is not easy. I have tried a couple of times, but I was not very successful. I mean, there's for sure a learning curve doing it, but it needs some training. So the traditional way of preserving the socket after extraction would be the membrane or membrane plus graft and the primary closure, as seen in many books. So we know that if we cover the socket with a resorbable membrane, and we have less alveolar rich resorption after tooth extraction. The main problem with this technique would be the primary closure attempt could end up in loss of vestibular depth. So if we mobilize the tissues on the buccal side to be able to make a primary closure, the result could be devastating. So later we have maybe the need to gain this vestibular depth again. So for this reason, many authors have given some recommendations. One of them was a mucosal graft from the palate, which may be a good choice for closure. Another one would be the membrane and leaving for open healing, for secondary epithelialization, like this here. Open healing with membrane needs 7 days later. You see here an uneventful healing. 3 weeks later, the wound surface is completely epithelized. And later on, you see uncomplicated healing. The condition when we can use this technique depends on the biomaterial which is used here. It must be resistant to collagenase. So it should be resistant to resorption. What is recommended here is the Ribose cross-linked collagen, which has extraordinary resistance. It was shown in studies that this kind of membrane was impenetrable for leukocytes, platelets, and fibrin from peripheral human blood concentrates. You can see here another case, which after the tooth extraction was covered with this kind of membrane. And you see after 3 weeks, the wound is epithelized, and 4 to 5 months later, it's not even visible. Studies have shown for this kind of membrane and this technique that this biopsy revealed regular keratinized epithelium on top of the lamina propria, which was densely attached to the newly formed trabecular bone underneath. You can see the trephine drilling biopsy here. Another possibility is a collagen block and open healing, so leaving for secondary epithelization, as seen here. It's a flapless approach, and there are studies showing that flapless approach, not mobilizing the buccal soft tissues, ends up in less bone loss. It is not meant, I mean, here with the collagen block, we don't mean the conventional collagen cones growth for stabilization of the blood clot. These would disappear in a couple of days and would not be able to preserve the bone. So I would like to show the socket preservation following tooth extraction. How do I see the whole thing in the latest time? Here you can see a root before extraction, which is then removed. And then I do use this collagen block, which I will introduce you later on. I put it in the extraction socket. There are different sizes available. Because the size is important, it should not be too small or not too large. The material has a limited compressibility. It should be kept in mind. You see here, I have compressed this a bit to show you. You can compress it a little bit, but afterwards it will crumble. So if you see here, we may compress a little bit, but beware of crumbling. As you can see here, it would not fulfill its task if it's crumbled. So that looks like a nice size, as you can see here. Do not take too small because it would disappear in the socket and not fulfill its task. As you can see here, you should choose the right size of the product and place it in the socket, as you can see here. This would be a little bit too small. You see, it was small sized. So we tried to fill all the gaps, but we still had gaps. If you are not sure about the soft tissues, you could make a crisscross suture for stabilizing the soft tissues. It's not necessary for the grafting material. It would not fall out. It will keep inside. Or as you can see here, if you are not sure, you can also use a glue for keeping the graft inside. Here you can see case where the extraction of the right upper first molar was not evitable. It should be extracted because of a fracture in the tooth root. And this is 6 months later after placing a collagen block inside. This X-ray may be deluding because of the property of this material. Radio opacity would only first be able to see after 9 months. I mean, you see here the situation clinically, and during re-entry, you see the volume is kept. Maybe the bone inside the socket could even more mature out if we wait a couple of more months. You can see here, but we have most of the time nice bone for implantation, as you can see here. If we do some trephine biopsies for histologically examining the part which has ossified, take away from the socket a trephine burr biopsy like this, and look up histologically what's happening there. We see osteoblastic activity after even 6 months. And you can see here, there are no remnants of the material left, although it is a xenogenic material. It is totally undergone ossification and provides true bone. And this is the radiographic view of the implant with the crown on it. When the buccal bone is missing, how can we proceed then? We know that combined defects makes the clinician really we have to keep in mind that big defects could end up in volume loss. So we are afraid. But with this material, we have also gained a lot of experience in such defects. Here, of course, we should keep in mind that this bridge is an advantage in our issue. But you see, the defect is big and you need a couple of blocks to fill it up. And then we have the filled gap. Maybe to be on the safe side, with these huge defects, an additional membrane would be beneficial. Again, the same material, a cross-linked, Ribose cross-linked collagen membrane, which can also be kept open for secondary epithelialization, as you can see here. So what about the immediate implantation after tooth extraction with combined preservation measures? I would like to draw an eye on this issue too. What about immediate implantation? If the socket is suitable for immediate implant placement, not as here, we can have very successful results. You can see here the first right upper incisor. It's result after 36 months. You can not easily see if there is a difference. And this canine, after 48 months, you can see it's no problem. And here we have to keep in mind that the buccal lamellar bone is intact. The tooth is extracted, and we will try to put the implant on the palatal aspect of the socket to avoid buccal placement or buccal positioning of the implant by fault, by mistake. It is important to have this positioning of the implant. But most of the time, especially in the front region, we will have a thin buccal lamellar bone, which will make our task difficult. In most cases, in the front, we have 1 millimeter or less bone width. And at least 50% of them have even less than 0.5 millimeters. There are studies showing that especially the immediate implant placement doesn't stop the modeling of the buccal or lingual even bone walls, and there is easily dehiscence seen on the buccal side of the implant if we do not respect the thin buccal wall. The problem here is, if you see the histology of a tooth, this is the periodontal ligament here. You can see the cement. This is the tooth. And on this side, you can see the Sharpei fibers of the periodontal ligament entering the bundle bone. The famous bundle bone, as you can see here, will disappear as soon as the tooth is gone. So we will lose 0.2 to 0.4 millimeters of bundle bone inside the socket. If we have a remnant, a residual bone wall of 0.8 millimeters, there will only be 0.4 millimeters of buccal wall left, which cannot stay in place. It will be resorbed or atrophied immediately. We cannot depend on this. So we know that implants placed into fresh extraction sockets do not prevent alveolar bone from resorption. Applying the GBR principle using bone substitutes together with the collagen membrane has shown clear effects on preserving alveolar ridge height as well as ridge width. Soft tissue grafts or primary closure did not show beneficial effect on preserving alveolar bone. So, if less horizontal bone resorption can be expected by addition of a grafting material and by combining immediate implant placement with a GBR procedure, the horizontal resorption at 4 years amounts, like shown in this study, to 48.3% in the group without grafting material, whereas the other two groups significantly showed less horizontal resorption at the buccal aspect. So you can see in many presentations or in studies that it is proven to be a nice preserving measure to put grafting material in between the buccal wall and the placed immediate implant to preserve this buccal bone. But most of us maybe have seen this kind of results in the time. You see that on the buccal side of this premolar, there is a loss of bone volume, which after a couple of years may even show a dehiscence in the bone, and we could see a grayish shining implant through the mucosa. You can see here in an immediately placed implant with the technique I have shown you, it was insufficient to keep the buccal bone volume. For this reason, I have developed an own technique to overcome this problem. You can see here, I use the tunneled lamellar sandwich technique. I fill the gap in between the implant and the buccal wall, as well as the buccal side of this buccal bone lamel with a membrane. It's a special membrane. I will explain and introduce you this membrane. It is very useful for this technique. I also use hyaluronic acid. I mobilize the vestibular part of the implant until the mucogingival line, so that I have a good mobilized soft tissue buccally, and put the membrane, the thick membrane, the collagen membrane, first into the pocket buccally, and then turn it into the socket, and have this result at the end. I have done now some cases, and the results seem very promising. You can see here at the end of the surgery, this membrane is visible. So this part is out of under the periosteum, and it is a thin phenotyped patient. That's why it is visible, but it will keratinize later. And the other part of the membrane is in the socket, as you can see here, a couple of days later. And this is another case. You can see here the good keratinized tissue and kept bone volume. But if the buccal bone is not intact, I do not try to make the immediate implantation. I go another way then. Because the principle behind this, the philosophy behind this thinking is the repairing or wound healing speed of the bone. The bone needs about a month to go 1 millimeter. I mean, it is much slower than epithelium or connective tissue. So if I would place an implant, I would stop the osteoblastic activity from this side. It would only depend on this thin buccal wall, and for my believing, it is not sufficient for building enough sufficient bone vestibular part of the implant. So I go another way. I fill the gap as with biomaterial as osteoconductive placeholder. I use again this Ribose cross-linked collagen block. What is O6 bone? What is this cross-linked collagen block? It is a sponge-like ossifying block for true bone formation powered by clinically proven Glymatrix technology. The ossifying collagen sponge has some benefits. It's easy to use. It undergoes ossification, provides true bone. It leaves no remnants like other xenogenic materials. It has no migration of particles. It is cost-effective for doctor and patient. It can be used in socket preservation and closed sinus elevation without a membrane. It has predictable results and consistent efficacy. It can be used for socket preservation following any extraction procedure. It can be used in lateral and vertical bone augmentation prior or conjunction with implant placement to correct bony defects in implants with peri-implantitis, in periodontal bony defects around teeth. It has osteoconductive properties, as you can see here in enlarged figures. It has additional advantage through resorbable synthetic hydroxyapatite crystals, as you can see here. And when you compare with other biomaterials, 6 months after procedure, you can see here a good preserved volume and successful incorporation of the graft with the O6 bone. And this is the histological view of the same case. We can, as a summary, say that this material undergoes ossification and provides true bone, leaves no remnants, can be used without a membrane. During my search, I have also found this material, which seems to be similar because of the collagen type and also the calcium phosphate put into the spongy tissue. Could be interesting too. This is the Ribose cross-linked collagen membrane I mentioned in the beginning for the open secondary epithelialization technique. It is the same material as the block, but has no hydroxyapatite particles. And this is the O6 Volumex. The name is for the volume in comparison to the other membrane. The other membrane has about 0.3 millimeters of thickness. This has about 1.5 to 2 millimeters thickness. Since not condensed, it has more open fibril structure. You can see here easily for osteoconductive purposes. It is multi-layer with different fibril density in each layer. Another indication for this kind of membrane is also alveolar ridge augmentation. As you can see here, this is a case of mine where an implantation in the lower left side was not possible, as you can see here. I have used this thick membrane alone with hyaluronic acid as horizontal augmentation possibility. And the patient has unfortunately disappeared for 14 months. And 14 months later, we had the opportunity to look back again and had this kind of bone at the place. You can see here, it was a nice, really matured bone. So we could place 2 implants. This is another case of mine where this tooth has had to be extracted. As you can see, there is a big defect here, and I use the same technique for the augmentation purposes. And after 7 months, we had this clinical view, and I placed the implant inside. For ridge augmentation, in these 2 cases I've shown, I used this membrane in combination with hyaluronic acid. Here another case from our department. You can see here loss of the buccal volume of bone after implant placement. And this site is also augmented with this thick Ribose cross-linked collagen membrane. And this is the end situation. Here another case, advanced ridge atrophy, you can see here, and then the same technique. And you can see here the gain of bone after about 8 months. There is not much literature about this material. I'm sure in the next years we will hear a lot of new information about this material, but one of the few publications say it is really promising. This one from 2019 shows that the regeneration procedure with the collagen scaffold was very successful. The results show that restoration of the lost tissue volume is achieved, and a favorable lifelike emergence profile for the crown is gained. Another important biomaterial we use, which I always mentioned in the presentation, is cross-linked hyaluronic acid. What is it? It's a natural part of the extracellular matrix. It is synthesized also in periodontal tissues. It is synthesized from fibroblasts, cementoblasts, osteoblasts, from keratinocytes on the gingiva and periodontal ligament. It is bacteriostatic and also fungostatic. It is anti-inflammatory, anti-edematous, osteoinductive, and also pro-angiogenetic. So miracle material, accelerating wound healing, cell proliferation, and hyaluronic acid is produced by bacterial fermentation from streptococci. So it is not xenogenic origin. There are no known side effects in dental treatments. So I would like to conclude here my take-home message. Socket preservation is easier, more economic, and more successful than later augmentation efforts. The timing of implantation should be adapted on the needs and preferred technique. The timeline of ossification and volume preserving depends on the methods as well as the used material. So if we use a material which is resorbed in 6 months or 8 months, we could plan our implantation in this time schedule. If we do not use any preserving methods, we should know that this bone volume will be lost very soon, and maybe keep the time period shorter and the implantation sooner. My choice, I can summarize as this: immediate implant placement with simultaneous sandwich technique if bony walls are intact and if the socket is suitable. I use this, of course, most of the time in the front region where the buccal wall is thin. If you have a buccal wall of 2 millimeters or 2.5 millimeters, I would not use this technique. If the socket is not suitable for implantation, so we go for socket preservation with a Ribose cross-linked collagen block and open healing, even if the bony walls show defects and or deficiencies. In case of larger defects, an augmentation with the Ribose cross-linked thick collagen membrane and hyaluronic acid is my way of going. Thank you very much for your attention, and I hope I have time for answering questions.
Well, Dr. Bilhan, that was a fantastic presentation, and thank you so much for sharing all your wisdom and knowledge with us. So I guess, ladies and gentlemen, let's see if you guys have any questions for Dr. Bilhan. Oh, I guess I was muted before, so let me say that again. Thank you very much, Dr. Bilhan, for the wonderful presentation and for sharing your wisdom and experience with us. It was extremely interesting, and as I said earlier, I think socket preservation is a key for healthy implantology long term. So let's turn to our audience and see if they have any questions.
Looking forward.
It says there's no questions from the audience. I guess we'll wait a minute, and in the meantime, let's wish all mothers a happy Mother's Day once again. And this is a very interesting method, the way you do things. And I think what I recommend for beginners especially is to start with simple cases that have buccal bone and try to graft them so that you learn the technique, and then gradually progress into cases where you might have missing buccal bone, etc. So there is a learning curve, but I highly recommend all clinicians should be versed, at least to a degree, on socket preservation. So on that note, and on behalf of Global Summits and myself, Dr. Bilhan, thank you so much for your time, and we look forward to our future meetings.
I'm honored to be with you, Pavel. Thank you very much for this great invitation, and I hope we see each other soon again.
Pleasure. Thank you. Bye, everyone. Kisses.